All right, everybody, we're going to get started. There are some seats over here in the right-hand corner, or your left. So if you want to find a seat there, please feel free. Welcome to our healthcare speaker series here at the Heinz College. I'm Alex Lutz. I'm the director of the Healthcare Policy and Management and Healthcare Analytics and IT programs here at Heinz. I know we've got lots of Heinz faculty, students, and staff in the room, but I also want to welcome, I know we have a big turnout from our broader CMU community, some folks from the University of Pittsburgh, and also a number of people watching on our live stream today. So we're really excited to have you all here. I think this turnout is a reflection of the fact that healthcare touches everybody, and we've got a really exciting discussion today that's really relevant to our primary and general election coming up. So we really want you to get a lot out of this today, and with that, I want to introduce two of our student leaders here at Heinz, Jana Matsiskova and Sean Cuff. They're the leaders of our healthcare and policy and politics clubs here at Heinz to do our speaker introductions.
Hi everyone, thank you for being here today. Thank you also to Alex and the healthcare programs at Heinz for making this event happen. And thank you to our panelists for sharing your insights with us. My name is Jana. As Alex was saying, I'm president of the Heinz Healthcare Club, and I'm a second-year Master in Healthcare Analytics student.
Yeah, and I'm Sean Cuff. I'm second-year Public Policy and Management, president of the Heinz Politics and Policy Club. Really excited to be a part of this and hear such great research and understanding of what is becoming one of the single biggest issues in the nomination process right now. So I'm excited that we get to play a role in this as well.
So diving straight into the introductions of our panelists, we're going to start off with Professor Jane Abraham. Professor Abraham is the Wegmiller Professor of Healthcare Administration in the Division of Health Policy and Management at the University of Minnesota School of Public Health, and she's also the director of the Master of Health Administration program at the university. She's also an alumna of the Heinz College Ph.D. program. Professor Abraham's research expertise is in health economics and policy. She has published more than 60 peer-reviewed articles investigating issues such as workers' access to and cost of employer-based health insurance, the effectiveness of employer wellness programs, competition in insurance and hospital markets, and the impact of federal health reform on individuals, insurers, employers, and providers. Professor Abraham has served as the senior economist on health issues for the President's Council of Economic Advisors in Washington, D.C. During the Bush administration, she provided technical expertise to White House senior leadership, and during the Obama administration, she participated in the interagency process to develop policy positions later adopted as part of the Affordable Care Act.
Great. And Professor Martin Gaynor is the E.J. Barone University Professor of Economics and Public Policy here at Heinz College. He was the director of the Bureau of Economics at the U.S. Federal Trade Commission from 2013 to 2014. Professor Gaynor is one of the founders of the Healthcare Cost Institute, and he's also an elected member of the National Academy of Medicine and of the National Academy of Social Insurance. He's also a research associate at the National Bureau of Economic Research and an international research fellow at the University of Bristol. Professor Gaynor's research focuses on competition and antitrust policy, particularly in healthcare markets. He's written extensively on the topic, testified before Congress, and has advised international governments on policy implementation. Professor Gaynor is on the Pennsylvania Governor's Health Advisory Board, and he's co-chaired the state's working group on shoppable care. He has developed a set of policy proposals for the Brookings Institute to make healthcare markets work to serve all Americans, and that research will be coming out shortly in early March. Professor Gaynor has won a number of awards for his research, including the American Economic Journal Economic Policy Best Paper Award, the Victor R. Fuchs Research Award, the National Institute for Healthcare Management Foundation Healthcare Research Award, the Kenneth J. Arrow Award, and the Jerry S. Cohen Award for Antitrust Scholarship, as well as the Robert Wood Johnson Foundation Investigator Award for Health Policy Research.
And last, but certainly not least, we have Professor Amelia Haviland. Professor Haviland is Professor of Statistics and Health Policy at the Heinz College. She's also the Director of AI and Analytics for Good Initiative at the Carnegie Mellon Block Center for Technology and Society. Professor Haviland's research focuses on causal analysis with observational data and analysis of longitudinal and complex survey data applied to policy issues in health and criminology. For example, she recently led a team of researchers assessing the effects of high-deductible, account-based health insurance plans on healthcare costs, use, and disparities in the most comprehensive study on the topic to date. Other health policy work involves assessing mechanisms for health disparities for Medicare recipients and exploring connections between patient safety and recent reductions in medical malpractice claims. Prior to joining the Carnegie Mellon faculty, Professor Haviland was a senior statistician at the RAND Corporation. She's the recipient of the Anna Loomis McCandless Chair, a Thomas Lord Distinguished Scholar Award, a MacArthur Fellowship for Younger Scholars, and a Ray Jackson Smith Scholarship. So with that, please join me in welcoming our esteemed panelists.
Well, I want to thank all of you for showing up today and listening and participating. This is really one of the most critical issues facing our nation today, and I'm very grateful to Jean for coming in from Minneapolis for this, and Amelia for coming downstairs. By the way, there's an assignment in R that has to be completed by Professor Haviland. I'm acting as the moderator. Before we get started, let me just say one thing. We are certainly going to allow time for questions after towards the end. And there'll be an opportunity to ask questions. There'll be someone with a microphone that will come around. So one, if you want to ask a question once we've opened the floor, please raise your hand. Someone with a microphone will come to you. Two, make sure it's a question. This is not an opportunity to recite your manifesto on the U.S. healthcare system. And one question, and please keep it brief. I'll remind you about that when time comes. So here we are. U.S. healthcare, about 29 million of us have no health insurance whatsoever. This is after the passage and implementation of the Affordable Care Act. But at least the system we have costs about a lot of money, about $3.5 billion. We're spending almost $11,000 per person for everybody. That's from infants to the elderly per person in the United States. There are incomprehensible and egregious practices, supposedly not-for-profit community hospitals, going to debt collection agencies to go after people who have to pay their bills while earning millions or billions of dollars in not-for-profits, surprise bills, serious problems with access to health care and poor health outcomes for many Americans, particularly the least vulnerable among us. Outside of that, we're doing great. So let me turn to Professor Abraham with the first question. There have been a lot of policy debates recently about incremental reforms that build on the system that we have versus something called Medicare for All, which often means different things depending on who's talking about it. Could you help us understand the broader historical context of healthcare reform in the United States, both well before the Affordable Care Act and leading up into the passage of the Affordable Care Act in 2010?
Sure, thanks, Marty. So I'm delighted to be here, by the way. It's nice to be back and to see all the wonderful things and to see all of you, because this is a fantastic turnout. As we think about federal health reform, this is not a new concept across kind of the U.S. history. There have been many different times that there have been attempts at health reform, really going back to the New Deal, kind of through the Great Society where Medicare and Medicaid were passed, through an era of cost containment in the 1970s given inflation, and then, of course, the Health Security Act proposal under the Clinton administration, which is kind of our most recent example prior to the ACA. The ACA, of course, is now a decade old, and it has addressed, of course, a number of issues relating to coverage, but less so focused on costs. And really across kind of our history, Each time that becomes a priority, we have to think about, why and how and what are the circumstances. And so as we talk today, I think really thinking about what is the political context, who's in power, who's running the executive versus the legislative branch, what is the economic context or environment? Are we in a recession or are we in strong economic growth? And then how will potential stakeholders in any health reform debate respond to the particulars? And here I think about consumers or patients. I think about healthcare providers, hospitals and physicians. I think about payers, so private insurers particularly, as well as other suppliers in the healthcare sector like pharmaceutical companies. All of that has to be framed as we think about health reform, and a lot of stars have to align for health reform to happen, and we're going to talk about some of that today.
Great. And just maybe let's return for a moment to not getting deep into the weeds, but some of the details. So you mentioned that the Affordable Care Act, which is now 10 years old, amazingly so, mainly focused on coverage.
Absolutely.
What are some other aspects of health care reform in addition to coverage that either are being discussed today, or whether they're discussed today or not, should be on the table as we think about reforming U.S. health care?
No, that's exactly right. So of course, the ACA was a coverage first, cost second type of reform. It focused on expansion through public mechanism, through Medicaid eligibility, and through the private individual market. And we think about affordability here in the context of redistribution, right? We basically are subsidizing individuals vis-a-vis Medicaid and subsidized individual coverage to enhance affordability. What it didn't do, and I think what is becoming apparent, is that for the broader population, costs continue to rise. And so the ACA was not equipped to deal with that kind of head on. What it did do beyond kind of the coverage expansion was to improve access via regulatory reform of insurance markets, and then it also dipped a toe in the water of value-based payment. And that's actually an area where I think we need to be having more of that discussion. I would argue that a lot of what we're seeing today in the debate is still really focused on insurance and to a lesser extent cost. But that's something that fundamentally, payment reform is something that needs to come to the front burner as we think about serious healthcare reform to address costs in this country.
Great, thank you, Jean. And I'm sure we will return to talk about costs, which is really sort of one of the very important aspects that you're right, has not really been addressed. But let's turn actually to one other aspect of this, and that has to do with disparities across different groups within the American population. And let's start by talking about Medicare and Medicaid, which are core federal state programs that often form the basis for many discussions, at least in the Democratic Party, about health reform. Amelia, you've looked at these issues quite a bit about population disparities, and they're a very serious issue. Would you like to talk a little bit about that and about the Medicare and Medicaid programs? What issues get addressed, what issues do not get addressed through those programs, and what are some things that we should be thinking about with regard to health reform and helping these folks who are in these positions where they really are suffering from poor access to care, poor health outcomes, and other sorts of issues.
Sure. Thanks, Marty. Yeah, I have done work in looking at disparities for a long time. There's been a couple of decades of looking at it. One of the things that let's get it on the same page. Medicare is the health care that's provided based on age for everyone who's 65 and older, right? So that's an age-based program, almost all. There are a couple other ways you can qualify, but that's almost all of it. Medicaid is for people who are quite low income, right? And that's a state and federal program, so all the rules around that vary by state, okay? Medicare is federal. So Medicare, Medicaid. One of the things that all of what I say is contingent on is the aspect of Medicare that it's regulated, right? So that there's oversight of the government over all of that care, and some of it is, about 70% of it, is what we call fee for service in terms of the payment mechanism. that anybody in Medicare can go to any doctor at all. All doctors accept Medicare insurance. It's just too many people for doctors to not accept Medicare insurance, right? So you can go to any doctor through fee-for-service. And then about 30% of people enroll in a private managed care Medicare plan. So that's the private insurance companies coming in, contracting with Medicare. And so people go through those, and then you're in the usual private insurance kind of realm where there are networks and there are different kind of copay arrangements that go on separate from the fee-for-service. Okay, so that's the sort of setting that they're in. One of the things about quality, right, so we're talking about cost, right? So how many people are covered? How much does it cost? And what quality do we get for it, right? What are we getting for all of these dollars? In Medicare, one of the things that they've done is gotten pretty serious and I think done a pretty decent job of taking a bunch of steps to actually make the quality transparent to people. So they require all those private Medicare Advantage plans to report a bunch of information that then gets publicly reported, both about clinical care, so HEDIS measures, for those of you who speak that language, so there's a whole bunch of clinical care measures, patient experience measures, so they have to pay to survey their beneficiaries, their enrollees, to learn about what their experience is of getting access to care and the quality of that care. And then all that's publicly reported, and on the private insurance side, there is some pay-for-performance mechanism in there. That's part of the payment. And so everything that I can say about quality is because there is a lot of information that's been available for a long time about that quality. And they're starting to do some reporting by gender, by race, ethnicity, by geographic information, less by income. And so all of that information is available. So one of the high-level things that I think is interesting that we can learn about in Medicare, because there both is this government-only piece of it, and there's the private insurance company piece of it, where we have a lot of the same kind of information about both, is that we can start to compare. What is the cost and quality that we get when we go just through the government, right, which is Medicare for All, some versions of that, versus if there's a private insurance company that's in there, right, that's managing the care. And one of the things that we see on disparities is that the disparities tend to be bigger. Race ethnic disparities, income-based disparities tend to be bigger in the private managed care version than they are in regular fee-for-service Medicare. However, just to complicate matters, right, so here's the disparity there, here's the disparity there. The question is, where is this disparity in levels, right? And that really depends on what kind of quality measure you're looking at. And it really differs. There's some kinds of care that managed care seems to do a better job with. Getting a flu shot, for instance. People in Medicare who are getting managed care get flu shots at substantially higher rates than people with fee-for-service. And it's pretty important if you're elderly to get a flu shot. Right? However, the gaps between who's getting it seem the benefit of that disproportionately goes to people who are, who are not facing other disadvantages. The benefit of the managed care particularly goes to non-Hispanic whites who are higher income. That's who reaps that whole benefit. Other groups reap much less of a benefit, which is why the gaps are bigger there. So there are both quality pluses and minuses, and one of the things that I think is interesting is that we have all this quality information there because of the government oversight. And even though most people in the US get their insurance through employer-based insurance, we don't have access to any kind of quality information like that. It just isn't there.
Thank you. Actually, there's a general issue about access to information on the private side of healthcare, even basic information like cost, utilization, let alone quality or any other kind of measures, is not generally available. So I think personally this is, I think, reasonably on topic, that it's time for the U.S. to invest in a national healthcare data warehouse, data and information are part of our infrastructure, just like roads and bridges. And it's something we absolutely need to do. It has to include things just like we were talking about, Amelia. Let me return just to this issue a little bit and talk a little bit about health and health disparities in particular. So we know there are really marked health disparities across different segments of the population in the U.S. How much of those sorts of disparities are due to differences in access to health care versus other sorts of factors that are driving different folks in our population to have really different health outcomes? And I guess I'll start with Amelia if you'd like, and then return to Jean. In other words, sort of how much of this, if we reform health care, to what extent is health care reform really going to address or even touch some of these problems that we have?
Yeah, there's some nice setups for looking at different levels of access, and one of the first base ones is having insurance, right? And so while it's true that among those millions and millions and millions of uninsured people in the US, the plurality of them are non-Hispanic whites, the rate of being uninsured is much higher, almost double for the Latinx community, particularly African Americans. It's higher than for whites, but in between those two rates. So the first thing is just not having insurance, right? And so that's a piece, because it's very difficult to get access to care once you don't have insurance.
If I may interject, there's some important, very recent research that's come out that shows that insurance has had very large impacts on people's health. People who gained access to health insurance through the Medicaid expansion of the ACA were shown to have dramatically better health than those that didn't. Although the research evidence on this is still a little bit mixed, but I think that's a really strong and compelling piece of research evidence.
And the uninsurance rate is about double in states that did not expand Medicaid than states that did. So there's a huge piece that's related to that. Then there are things about whether you can pay for the care even if you have insurance, right? So there's a large chunk of people who get called underinsured, where you have insurance, so you have these nice negotiated prices as opposed to crazy prices, but you have to pay so much for it. And so there still is a large chunk of people, about 1 in 5 households in the US said that they did not get care when they needed it in the last year because they couldn't afford it. People declare bankruptcy. It still is the main cause of bankruptcy in the United States, is people who can't pay their bills. So that's the next level, is you have insurance, but you can't afford it, right? And then there are issues about the quality of care that people get into. So in hospitals, for instance, there's pretty good evidence that lower quality care that is received by African Americans and the Latinx community is mostly because of sorting into lower quality hospitals. So there's a thing about what kind of providers you have access to, and is it that people are disproportionately going to lower quality care providers, or is it that within the same provider, you're getting worse care? And there's evidence of both of those things for outpatient care. Yep.
I would just say, in terms of, as we think about kind of health disparities broadly, and I come from a viewpoint of a school of public health, as we think about financial access, getting care, but also thinking about the upstream, thinking about the social determinants of health. And I mean, I think particularly around, there is a lot of work ongoing around what investments healthcare delivery needs to make to think about moving upstream to address some of those affordability issues, but also factors that affect individuals' transportation, housing, food security, all of those factors that also contribute to health outcomes. And really, I think right now there's a lot of work to try to ask, what's the business case? And do we have payment systems that can help inform some of that? Again, that's kind of a part of a broader discussion around payment reform, fee for service versus value, and really paying for outcomes, right, as opposed to just care, the process.
Thanks. Yeah, so I think the evidence shows that better access to health care can certainly help, but it doesn't solve all ills. There are many health problems that people have that are caused by things other than lack of access to medical care. And so while health reform is obviously important, that's why we're all here today to talk about it, I think we also have to recognize that it's not something that will solve all of our social problems. I want to talk just very briefly in terms of the Affordable Care Act, and then don't worry, I know you're all here to hear about Medicare for All and the other proposals. We're going to get to that. But Affordable Care Act, 10 years old, major health reform. It sometimes gets lost in all the discussion about proposals for new things, that this was a huge piece of legislation, a huge reform to the U.S. healthcare system. It's been in place now for 10 years. Jean, you were part of the efforts that led to the ACA. Would you like to just review for us what you think some of the key impacts of the ACA have been? And now we have 10 years to look at what's happened.
We do, and in fact, there's actually more than 300 peer-reviewed studies. We've been busy publishing on the impact. But who's counting? That's exactly right. So, clearly the first order outcomes have to do with expansion of coverage, and we know that there are almost 15 million new Medicaid enrollees as a result of eligibility expansion in 37 states and the District of Columbia. That, of course, has opened the door to accessing medical care at very low or no out-of-pocket costs for that particular population segment. We also know the individual market has, that was the other main mechanism for expanding coverage. And today, 80% of individual market enrollees through the marketplaces receive subsidies toward their premiums. That has been a little bit more controversial in terms of how that rolled out. And again, I think that the affordability of coverage for that segment plus the broader employer population segment is really what's driving a lot of kind of the current drumbeat of public options and additional interventions. But I think what we know, of course, is that individuals benefited. We know that providers and payers benefited from this coverage expansion because now for providers, instead of charity care or writing off bad debt, they were able to get compensated for service provision. And of course, the expansion led to a large increase in demand for insurance, private insurance, as well as Medicaid managed care plans. So I think lots of different ways that we saw it. And then, more broadly, there have been some health benefits, but it's also just an awakening to the importance of financial access and that protection piece. And so we're really revisiting that now because I think we're 10 years later and costs have not, the cost curve has not been bent. And so we're going to revisit this to think about whether there are additional incremental things we can do, or do we need to swing the pendulum and go for something more kind of full replacement.
Great. Amelia, would you like to chime in? Any thoughts on what the impacts 10 years out of the ACA have been?
Yeah, the big one again is the reduction in uninsurance and people not having insurance. It's 20 million fewer people, I think. And although we've had about 1 million more people become uninsured each of the last 3 years, so that's getting chipped away. And of course, we have these legal challenges to the ACA right now. So in addition to things that we might be dissatisfied about it solving everything, right? It had a huge impact, but solving everything, we also don't know that it'll stick around.
We don't, and that'll be the case to be decided. I guess one thing I'd failed to mention, of course, is the people with pre-existing conditions, which was clearly a key factor in kind of the road we've been on around the attempt to repeal and replace and protecting that segment of the population, which is, that was a real issue pre-ACA. It affected for many of us, we probably know somebody who was affected by that. And I think that regulatory change was notable, and it will be interesting to see how that kind of carries forward. But again, there's a lot of uncertainty going forward with the case of Texas versus the United States, and it adds a lot of it makes the stakes higher, I think, as we go into this election, because that will likely be determined after the November election, and so that could put us on a very different course.
Thanks, and I think that's really important background. So we've seen the ACA is certainly quite successful in expanding insurance coverage, although there are many of us who still have no health insurance. And as I said, there's really compelling research evidence that those coverage expansions really did have an impact in an important way on people's health. One dog that didn't bark is cost control. Cost basically continued on the pattern as before, and that's important in many ways, but in no small part because it affects affordability. Why is health insurance so expensive? It's so expensive because healthcare costs are expensive. 80 to 90% of health insurance premiums are medical expenses. They were before the ACA, but they're actually now by law required to be 80 or 85% depending on certain conditions. So health insurance is expensive because healthcare costs are high. If we get healthcare costs down, we can make health insurance more expensive. So that's one dog that didn't bark. Another dog that didn't bark that there was a lot of discussion of beforehand was whether there would be problems with access because of increased utilization due to increased insurance, and whether hospitals, doctors, nurses would actually get overwhelmed. That didn't happen. Now, this was about a 20-some-odd million increase in number of people with insurance. That's not trivial by any means, but that could be relatively modest to whatever may come next. So actually, let's turn our attention to the sorts of things that are being discussed by the various Democratic candidates. And there, as all of you know, I'm sure many of you have watched the debates or listened to the radio, newspaper, what have you. There are roughly two kinds of proposals. The one that's gotten a lot of attention, very prominent, is called Medicare for All. Bernie Sanders is proposing that. Elizabeth Warren had a version of that. There have been multiple versions of Medicare for All, but the idea is that rather than what we have now, the U.S. government would provide health insurance for everybody in the United States. It's called Medicare for All because the idea is we take the Medicare program, which exists, and just expand that to cover everybody in the United States. There are other versions that say, well, are a bit more incremental, say, let's take what we have now, private health insurance, Medicare, Medicaid, the health insurance exchanges through the Affordable Care Act, but let's expand and those things address issues in the current system. Many of these have proposals for what's called a public option, a health insurance plan that people could sign up for, possibly pay into, that would be run by the U.S. government and offered alongside private health insurance plans. So many of the other candidates, I think most of them have something like that. And there are lots of different flavors of these things, many more versions of health reform than flavors in an ice cream store. So it can be kind of confusing. But let's talk about this. What are these proposals trying to solve? First, what is it they're trying to address? And then what are some of the likely impacts? Or let's start talking about pros and cons associated with broadly what has been called single payer, Medicare for All type proposals versus take the current system and add to it or fix it. Amelia, would you like to share some thoughts?
Sure, I'll start us off. Yeah, I mean, so certainly coverage, right? So all the folks who are still uninsured is still an issue, and then the different plans address it to a greater or lesser extent, right? So the Medicare for All, one of the things that just sweeps, everybody gets Medicare, right? You're done. So there is nobody who's uninsured except for issues about people who are undocumented. So that's one thing. The public option, the idea is that it would be such an attractive thing, it would be cheaper, and the quality would be good enough that you would pick up those people who are uninsured now through the public option. But most of the models I've seen don't suggest that you would pick up anywhere near everybody. You would pick up some folks, right, is the idea. So that's the coverage piece of it, right? Then there's whether you can afford the coverage you have, right? So I like this. There's some nice examples of this. So on the ACA, on the exchanges, you can see exactly what your coverage is. Again, the government oversight means they had to show you what was in your coverage in a much more transparent way. And most people who get their insurance on the exchanges have quite high deductibles. They have about a $6,000 deductible for those. It's the vast majority of people are in high deductible plans. There's a cap on those deductibles, but there are a bunch of them in the $3,000 to $6,000 range. They are now saying that about 40% of U.S. households say that they cannot come up with $500 extra in a month. Like, they are living too close to the edge. They can't come up with $500. So here's the $500, and here's our $6,000, right? So that's the underinsurance problem, right? I myself, maybe many of you do, know people who have declared bankruptcy in the last year because of medical debt, right? But if you have a medical problem that goes over 2 years, then you're at $12,000, right? So Medicare for All is offering a quite generous plan, Bernie's version, with little to no cost sharing besides at the point of care. Let me put it that way. At the point of care. Little to no cost sharing at the point of care. So there where you're deciding, am I going to not go to the doctor, right, because of these high costs, that's gone. The public option, it's less clear how all of that's going to happen. And there's nothing explicitly in those that are about payment reform, that are about trying to do pay for performance, that are about trying to do any of these affordable, accountable care organizations where people are sharing risk. There's none of that explicitly in the plans that I've seen. There, that's my start.
Great, that's a great start. So let's continue to talk about coverage and expenses borne by individuals. Then we're going to want to talk, I think, about how do you pay for this stuff, and then lots of other issues to talk about as well. Let's talk about coverage and sort of the financial burdens on individuals.
Right. So, I mean, right now in this country, if we think about if we think about across the different segments, insurance segments that we have, as Amelia just alluded to, for individual market enrollees, those particularly who earn above 250% of the poverty line, they are bearing pretty large out-of-pocket cost sharing at the point of utilization in the form of deductibles and co-insurance. But that's not the only group affected by this. Those with employer-sponsored insurance also are facing fairly significant out-of-pocket cost sharing, both in the form of the premium contribution as well as deductibles. So the most recent evidence from the Kaiser Family Foundation indicates that a single coverage average premium is over $7,000, and a family coverage policy is over $20,000 per year. Now the majority of that tends to be borne by the employer, but ultimately workers who will pay for it through part of their compensation. But even the out-of-pocket share is averaging $6,000 for a family policy. So that's the worker's contribution. And then on top of that, we have deductibles. The average deductible for an employer policy is north of $1,600 a year, okay, with lots of variability across plans. So there is a lot of exposure. And then, and that, the private insurance segment's not the only segment exposed. Medicare, even though people love their Medicare policies, there's no out-of-pocket limit for traditional Medicare. So folks will end up buying supplemental coverage to try to wrap around that or face some risk there. So, so cost, people feel it, and it's, we know it, we experience it, and surprise bills are perhaps one of the worst examples of, people who have no control over knowing what they're going to be obligated for until after the fact, and we see that in the headlines all the time. So cost is not going away, and the options that are being proposed, again, fall along a spectrum from kind of the public option, incremental. We can get premiums down via administrative efficiencies and perhaps get a better deal on payment rates, to Medicare for All, which is a pretty blunt tool, but gets us at universal access. I think it's a spectrum on design. It's also a spectrum on who would be affected by the proposal.
Great, thank you so much. And yeah, I mean, there are a whole bunch of statistics out there about the burdens of healthcare costs on the U.S. population. Typical worker in the U.S. hasn't had an increase in their real take-home pay in years, while the costs of health insurance, whether those they bear directly or the employer pays for, have gone up and up. If you look at budgets for an average family of four in the U.S., spending on health care out of their budget has increased steadily, while spending on pretty much everything else you could think of, food, clothing, rent, everything else has been declining. So it's really eating into people's ability to maintain a standard of living or achieve a standard of living that they desire. Let's talk about overall cost and how we might pay for this. This has been an intense topic of discussion. Again, if you've followed, it's come up in debates, there's been a lot of media coverage. So I want to have us talk about that, but I don't want us to stop there. I think there's been a little too single-minded focus on what's this going to cost, how are we going to pay for it, and then trying to play gotcha with various political candidates' proposals. That's politics, after all. But I think we also need to talk about other sorts of things: access, waiting times, innovation, quality, etc., employment, that are also very critical, but haven't gotten the kind of public attention that I think they really deserve. So, Jean, I'll start with you and then turn to Lee. Talk a little bit about the actual cost, best that we can get a sense of it, under these various proposals, and how we as a country would go about paying for these things.
Sure. So I'll start with the Medicare for All case, since there's been kind of a little bit more on the financing of that. It's also the bigger ticket item. What we have seen in terms of, we don't have actually an official score from the Congressional Budget Office on this, but we do have some preliminary estimates that suggest the Medicare for All proposal, closest to Senator Sanders, would cost about $1.2 trillion in excess of the status quo per year, okay? And so if you actually, and that's a pretty conservative estimate, but if you think about, one way I've been thinking about this is to compare it actually to what the cost of the ACA was. Now granted, it's a much bigger proposal, but if you actually were to take the ACA's cost from 10 years ago and inflation adjust it, Medicare for All is about 10 times the size, okay, of the cost of the ACA. What I think is important to also think about is the idea of the importance of thinking about the benefit design, so balancing off the affordability versus what that will do to demand for medical care and for potentially supply side capacity constraints, because I do think that's a non-trivial issue to think about. And then the other kind of piece of this that is interesting is to think about under Medicare for All, it is a massive structural change in who is actually financing and supplying the insurance, where you would displace the private insurance industry. And that's something we have to kind of really grapple with, because in the current state, a third, 20 million Medicare beneficiaries have private insurance. And so I have struggled with this idea a bit because we're really reverting back to something that could be much more like traditional Medicare. But the benefit, of course, of traditional Medicare is its administrative efficiency. It's about one doesn't know exactly, but somewhere in the 3 to 6% range of costs are for administration, relative to much higher costs from a private sector side, not taking account of this profit motive that many health insurers have. So I think those are kind of really key things. Paying for it is that's a tough issue. That was one of the things that I worked on under the ACA. I got the lovely, pleasant task of sitting on the group thinking about how do you pay for health reform. And you have to think about where do you make cuts, and does it come from from ways you pay providers or other types of things, or how do you tax? What ways do you raise revenue to cover those costs? And we have to think about, there's public finance issues that really are very complex that have to be thought through, because nothing is static, right? For everything you do, there will be a response, And so it's often, and that's just economic response, there will be a political response too for most things. And we've seen that borne out with the ACA.
Great, thank you. I'm going to turn to Amelia, but I'll throw a couple things out there that you can either take on or Jean can take on in response. One is, one thing to think about in terms of overall costs, and I'm going to talk about Medicare overall for the time being, is our offsets. So in a proposal that I believe Sanders has, Medicare for all would replace every single kind of insurance. There would be no more employer-sponsored health insurance. So all those costs would be gone. Like there would be resources freed up that would be available for various other kinds of uses. So that's one thing to bear in mind. Yes, there's a huge increase in U.S. government spending, but there's also a big decrease in private spending on healthcare. That's one. Two, this has been the subject of a lot of discussion, is what sorts of reductions in the cost of care or insurance might be available. One of these is administrative costs. The other is under Medicare for All, there's only one entity buying care from hospitals, one entity buying care from doctors, one entity buying drugs from a pharmaceutical company. So if you want to sell your drug or your hospital treatment or your office visit, you've got one entity to do it. It's going to be a take or leave it situation. That may also be a potential source of savings. It also could be raise some supply issues as well. So I'd like to see us chat about that, and also not to forget more incremental proposals that take our system and add on to it. What about the costs of those? What sorts of savings might be available through the kinds of proposals that take what we have now and modify and add on to it? So I apologize for that long intro, but Amelia, please let us know your thoughts.
I feel funny jumping in on you to talk about prices, but I will. Here we go. So
You cannot talk about it enough.
there we go. So let me do my hands thing again. Here's Medicare, how much Medicare pays for care, for actual medical care that you get at the doctor or in the hospital, right? Here's how much they pay. Here's how much Medicaid pays, right? Which is why a bunch of providers don't accept Medicaid patients, right? Because the payment rates are too low. Here is private insurance. Higher? Okay. Here's private insurance. Okay, and the uninsured, the prices that they get charged are about on the ceiling. Okay, that's the price that they get charged and that they go into debt for, right? That they go. Okay, so that craziness aside for just a moment. So Bernie's Medicare for All is saying that the payment rates would be at the Medicare level. So there are a bunch of hospitals that are saying, we're going to be in big trouble if you do this, right? We're going to lose those higher payment rates from the private insurance companies, all individually negotiated between each insurance company and each provider. So some people we're paying for all of that when we pay for our care too, right? So all of that, it's going to be down here. But for hospitals that are serving a bunch of the Medicaid population, their payment rates are actually going up to the Medicare level. And all this stuff about chasing bills and trying to get the payments from all those people with the $6,000 deductibles who can't pay it, and the people who are charged that price and they can't get anything for it, right? They're now getting paid at the Medicare level. But there are a lot of questions about if there are a bunch of doctors, can the hospitals make it work at that level? They're making a lot of noise now that they can't. Can they or can't they, right?
And I think the political viability piece here is a really important detail to think about, right? Because, and I'll swing back to the incremental case of a public option. So the state of Washington is our first mover around having a public option. And it's a pretty, they had very grand plans. And when all was said and done with the politics of it, they ended up with a public-sponsored plan using private insurers and negotiating rates at Medicare at 160% of Medicare. That was the best that they could get to. So that's a long way to 100% of Medicare, and I think that is where most of the public option savings is born out of. It's basically the getting better payment rates and driving expected medical spending down, which then translates into lower premiums. And so that's a fight. As I kind of, when I started the conversation, I talked about stakeholders and winners and losers. And I think any political debate that we have, they're gonna be front and center. Just as an anecdote, when I was working in the White House, the private insurers were there every week. They were flying in, their executives were meeting to lobby and talk about their positions. And so this doesn't happen, policy doesn't happen in a vacuum. You have to kind of think about the political context too.
Right. If I may add, the theory behind public option is not just that a public health insurance plan that's present with private plans could do better. It's that could drive the entire market. So if you have a public option, and that public option can get good prices from hospitals, doctors, pharma companies, et cetera, imaging centers, and it has low administrative costs, that puts pressure on private health insurance plans. They have to keep their premiums down or offer something or make people want to choose them. They'll then turn around and put more pressure on hospitals, doctors, pharma companies, imaging centers, et cetera, and that could help drive costs down. Now, that may or may not be the case. That's a theory. That's a story that has some plausibility, but we don't yet actually have much evidence on it. And Jean's 100% right. We're going to talk about this sooner or later. The politics of healthcare reform are very difficult. It was not an easy matter to have the Affordable Care Act passed at all. This is already facing very stiff. The notion that there even might be a Medicare for all option before anybody's been nominated to run for president by the Democratic Party is facing huge opposition from industry groups because they're concerned that if rates get pushed down, and 160% of Medicare would be substantially lower in many places than private rates, that it's going to come out of their wallets, and they don't like that idea. By the way, I think the notion that most hospitals would go under if they couldn't balance their so-called losses from Medicare with private rates is just a bunch of baloney. They're clearly talking about tears. It's not true for all of them. There are some small hospitals, particularly those in disadvantaged areas or rural areas, they're having a tough time. But really the main reason those places are having a really tough time is because they've been losing population. They're having a rough time just like everybody who lives there and all the other businesses that live there. It's not necessarily these rates that are driving the problem. So you hear all kinds of arguments put forth. Why not throw spaghetti at the wall? Some of it might stick. But I think you have to take those with a grain of salt. Let's talk about some other things. There's been this huge amount of talk about the cost of Medicare for all or something else. But let's talk about some other things. Might there be issues with access? Nearly every other country that has universal coverage, whether it's single payer or some other form, has an issue with waiting times. And I don't mean sitting in your doctor's office for 45 minutes reading a 20-year-old copy of Sports Illustrated. What I'm referring to are waiting months to have an operation or not having access to certain kinds of treatments, even for people who are severely ill. And this is not in countries that are not well off. These are wealthy countries like the Scandinavian countries, the Netherlands, the United Kingdom. These are very well off countries. So that's one issue that I'd like to see us talk about a bit that really hasn't been discussed yet. What about innovation? So the U.S. leads the world in terms of healthcare innovation. Some of that's pharmaceuticals, many of which are extraordinarily valuable. A few years ago, we had a new drug come out that cured hepatitis C. Previously it could be treated, but it couldn't be cured. Well, now it can be cured. And all kinds of other medical innovations. The U.S. leads the world in this area. What about not just medical technology, but organizing and delivering care? What about those sorts of things? What about quality of care? What about not just access, broadly speaking, but disparities? let's chat a little bit about a few of those things with regard to incremental reform, Medicare for all, or anything else. And Amelia, if you'd like to take that up, just a small.
We'll see where I go.
In the next, 2 to 5 minutes.
There was some piece of it I was going to carve off, but I got lost. Do you want to start, actually?
Okay.
Thank you. So I'll start with the wait time issue, and you're right. There's lots of anecdotes, increasing evidence around wait times. I think one thing we have to think about is that healthcare markets are fairly local. Healthcare delivery is fairly local. So any type of shock, like policy shock, that will kind of transform the system will likely have very different effects depending on what capacity looks like, kind of the uptake of newly insured, and then fundamentally how the benefit design plays out. Right now in this country, we're already anticipating primary care provider shortages. For those of us who access specialty care, again, it depends on where you are, but it's not atypical to see a 2 to 3 month wait to see a specialist in this country. So, I think there will be likely some significant issues and concerns. The one advantage is that, the advances we've made in technology should afford us hopefully better measurement of what those are. I think to date it's a little bit difficult to know given all the different systems and market environments. The other kind of point I'll just talk about is innovation, which is the other kind of talking point we often hear about. So if we move to this system, we're going to have private health systems and private insurers need that margin to be able to do innovation. We see the markup even in pharmaceuticals and medical devices. We don't really know what would happen there. I mean, I would imagine that clearly if they're still profit maximizing entities, they will try to figure out how to best deploy their internal resources, either getting more efficient or targeting more effectively. But I do think that the U.S., and this is particularly around pharmaceuticals, this is kind of a very common theme we hear, that you regulate us, you drop our prices, we won't be able to do it. I don't know of the evidence of kind of what exists elsewhere. We're kind of a unique entity in that we bear a very disproportionate burden globally around R&D as well as spending. So I think it's a real concern, and it will come out in the discussion if this goes forward.
Great.
I remember now.
Yeah.
So rationing care, I've been talking to researcher friends and colleagues for a long time about the fact that we already ration care, right? We get really panicked about the idea that these changes are going to give us a system where we ration care. And I always want to remind us, we are already rationing care. All those people who are uninsured, people who are underinsured, we're rationing care every day based on people's ability to pay. Okay, winners and losers, right? This is shifting those winners and losers. We're bringing those uninsured in, right? So there's more demand for health care because we're bringing those uninsured in, and we're dropping the price that we're paying those providers. So some of those providers may all decide to go do something else, right? So are we going to have even a harder time? So that's the question there, about to what extent, and we don't really know how many providers will decide to go do something else.
Right. Just
big influx of lawyers.
Supply and demand.
Right.
At the same time, the number of people that we admit into med school every year is severely limited. And we also limit the ability of physicians who obtain a degree outside the United States to come and practice. We also limit the ability of nurses and psychologists and pharmacists to do things they're actually trained and qualified to do. There are also limits on what can be done via telemedicine or telehealth. So something's gotta give. And it's not just covering an additional 29 million people, which I personally think is something we absolutely should do. But if you do that, at the same time you provide very generous coverage, you have to expect a large demand expansion. And if you don't do anything on the supply side, well, guess what? So let's talk very briefly about what's been coming out of the current administration in the White House. There are a few things. There are various attempts to roll back parts of the Affordable Care Act. They've been advocating for short-term health insurance plans or plans that have very limited coverage, provide coverage for low-cost healthcare events, but not for high-cost sorts of things. That's one of the things. They have made efforts in terms of provide and ensure price transparency. They've been talking about work requirements for folks who receive Medicaid. And there's still discussion actually about value-based purchasing that is going on. So I don't want to take up too much more time because I want people to have a chance to ask questions, but I thought it'd be good if we at least say something briefly about some of the things that are coming out of the current White House administration. I don't know, Amelia, would you like to say anything about any one of those?
I'll just pick up one of them.
Yeah,
The short-term plans are curious to me, like in terms of an insurance product. Like it's
They're not insurance.
right.
But they're acting as
They're horrible.
Right. I mean, I was thinking about it partly because they seem like they would have a problem that we worry about with the public option, but they would just immediately have it, and it would be the only thing that would happen with them, which is that you worry about there being selection problems in the public option, right? That if it's cheaper, what you're going to do is you're going to get everyone who's sickest, who goes into the public option, and then their costs will be really high, and they won't be able to stay cheap, right? That's the thing that you worry about there for the public option, unless you get enough people to do the risk pooling. That's exactly all that's going to happen.
I mean,
Right, but at least there's a lot of costs they won't cover at all.
That's true.
There is that plus.
I've always said
However-
That's why they're cheap.
okay.
however, I will say that, I mean, they were, it's kind of an incremental way of kind of trying to kind of take down the ACA or break it apart a little bit, one step at a time. What they did, though, I think one of the rationales of these plans was that, particularly for individual market enrollees who were over 400% of poverty, they were fully exposed to premiums. They didn't get any help. And so there are millions of people small business owners, self-employed folks, who were really struggling because that was their only source of coverage. So the challenge is that these are underwritten. These are medically underwritten, so you have to essentially be helped. It's pre-ACA. It is really just reverting back to the pre-ACA world, allowing people to buy these plans. They have very large kind of loading and profit margins on them, but they provide some basic coverage, albeit very basic coverage. They're not good quality. But that's, and we don't have good data on them either, I will say. I went trying to hunt down a statistic, and I think about 1 million people have them per year. But it's really catastrophic and really not great coverage. But for some people, that is the only thing that they may be able to qualify for and afford in the short run until we get to a better, more affordable public option or some other alternative.
Thanks. Any other thoughts, either Medicaid work requirements? Work requirements, is that a sensible? Does it
It's
achieve?
politically appealing, but what we're seeing, work from Ben Summers, Arkansas, not finding much effect, big coverage losses and not much uptick in employment.
Okay, so I think that we've spent a lot of time talking among ourselves, and it's been really wonderful, but I'd like to hear from folks here in the audience. So again, if you have a question, not a statement, a question, not a manifesto, state one question, take 10 seconds or less to state it. And it can be addressed to any one of us or all of us. Please.
Great. Hi. Thank you guys so much for sharing all of your insights. I really appreciated all of them. There was some mention of the cost of healthcare spending itself. And I have observed a number of studies released that say within a 10-year time frame, the Medicare for All policy as proposed in the Senate currently would result in a net savings on healthcare spending in total. And these have come from organizations across the political spectrum. But the question I have for you is that it seems like an incredibly complex question to estimate. Like, what is the cost going to be from everybody's spending in total under this hypothetical policy? And I'm wondering what your perspectives are on how reliable it is to make estimates like that and whether we can trust those findings.
Thank you.
That's a great question. So, when we do health reform, there are several private plus the Congressional Budget Office that uses micro-simulation models to try to project coverage effects and cost estimates, building in assumptions about payment rates and other things. I think that It was very notable that in May of 2019, the CBO generated a white paper that laid out an entire framework for how you actually do this. They didn't actually score it, the proposal, but they did lay out a wonderful paper. So if you're interested in thinking about health reform and how to model it, it's fantastic. And so I highly encourage you to read that. But it is difficult. That type of proposal is pretty far outside the realm of what our current system has and what we know about assumptions about how consumers and providers will respond. And that's what makes it so challenging to get a number that's believable, right?
I would just chime in that I think what we're looking for in those, what I'm looking for in those things is for them to be clear about what the assumptions are that they made and to show sensitivity to changes in those assumptions is the main thing that I'm looking for them to be useful.
Yeah, bottom line, I think it's really hard to do, and it's easy to see how different groups who are honestly just trying to do the best job they can could come up with very different numbers. And in no small part, just as Jean said, this is a really big change. It lies really well outside anything in our current experience, and it makes it very hard to extrapolate.
Although there are lots of other countries that are using this kind of system that
Right,
we can try to learn from, but we don't know how much it'll translate.
Awesome. Thanks for your thoughts, everybody. So quick question. I think all three of you touched on the political viability of something like Medicare for All getting passed, with the current state needing to pass 2/3 in the Senate. Curious your thoughts on where we could actually see some compromises similar to what Obama had to do for the Obamacare or ACA to pass, that Bernie might have to do. But given the fact that Medicare for All is more of an all or nothing approach, where do you make that compromise?
I mean, Warren has done one version of a compromise, right? So she's suggested that you wrap Medicaid into Medicare and that you drop the age down to 50. There does tend to be a big issue for people between 50 and 65, where if you are laid off, which happens for people in their 50s, companies are trying to drop people who are more expensive. It's hard to get a job sometimes in that age range, and so there is a drop there. So that's one thing, is that you expand Medicare some, but not that, and you add in a public option. So that's one of the options that's out there. The other thing that I'm surprised I haven't heard more of is you keep Medicare Advantage.
Medicare Advantage for all.
Right.
Right. It's interesting though, right? I mean, I don't know that. Don't quote me on this. Like the pricing, if you think about Medicare Advantage prices relative to kind of commercial prices in the sense of kind of the non-elderly, they're significantly lower, is my understanding. So they were able to get the squeeze on the prices down, which is again how you get a lot of the savings. You just don't get the administrative efficiency and profit motive out of it as a result. So I don't know, that could be an interesting hybrid to think about.
Right, or I guess this is really just a version of what Amelia said. If you like your health insurance, you get to keep it, but if not, you can go into Medicare. And there certainly are systems like Australia where there's a national health insurance. Everybody gets a decent policy. Anybody who wants to purchase health insurance privately, in addition to that, they're certainly free to do so. So there are possibilities, and we'll see as things continue to evolve.
Great. So I have a question about sort of second-order labor market effects. So what are your expectations with respect to wage growth? If we distribute healthcare to being a government option, do we think it gives workers more bargaining power? Do you expect there to be more small business owners, more entrepreneurs who have that security of healthcare?
There were some of those claims around the ACA, is that it would lead to more entrepreneurship in particular, that kind of people staying in their job in order to keep health insurance, there would be less of that. Because for higher income people, the costs are still pretty high through the ACA, it wasn't a big effect that we were hoping to see. I mean, does anybody else want to jump in there? It's a really good question.
Definitely, maybe. It's a good question. So you might think you'd see labor market effects if you decouple health insurance from employment. And so wages, in principle, you think should grow. It's a little tough to say, I think, for a couple reasons. One, and we keep coming back to this, but it's true, it's a really big change. So that's hard to know. The other thing that shouldn't be overlooked is, well, healthcare is 1/5 of our economy. So guess what? If there's a reform that pushes down healthcare spending substantially, a lot of that's going to come out of wages, because most of healthcare costs are pay. And so if wages for workers in the healthcare sector get pushed down as a result of healthcare reform, maybe not. Those are just some things I think that make it hard to say.
There's also part of the funding that's often recommended for something like Medicare for All is an employer tax, right? So where instead of them paying the premium for their employees, they would pay something that's about 60% of the amount that they're currently paying for that in a tax. So it wouldn't be just all that money is floating around in the employers now.
Hi, over here. So one of the main thing of ACA was that you need to have you had individual mandate, right, which is not really active right now. So if there is a public option and you are not having an individual mandate, how do you think the number of uninsured would decrease? Do you speculate that individual mandate would come back?
I don't anticipate the individual mandate coming back. I do think, the reduction in the uninsured that would result from the offering of a public option would come through lower premiums. We know that individual market enrollees are very price sensitive, and so it would come through that mechanism. I think there will always be a segment of the uninsured population who are never going to sign up for coverage, given that they are still able to access, albeit through not optimal paths, i.e. the emergency room. But I do think that if the public option induces more competition and a lower priced offer, you will see some take up there. And that's being modeled out by some of our think tanks like RAND and Urban.
Hi. You two know what I'm going to ask. What are your thoughts on the Medicare for America proposal from DeLauro and Chakowski, which is the universal public plan with the opt-out for qualified employer coverage? Particularly, what are your thoughts around that US-specific proposal with respect to political feasibility and how the private insurance market might respond to that as like a middle ground negotiating tactic down from universal health care and single payer, but up from public option as it currently is being proposed?
I'm going to ask Jean to take the political viability piece of it.
I think the employer, even under the ACA, it was very challenging to navigate the employer-sponsored insurance and issue. And the one lesson I was taught as an academic coming into the White House by the political operatives was that politics will trump policy every single day of the week. If something is going to be bad for a politician who's on it's not going to happen. In the case of employer-sponsored insurance, people love their employer-sponsored insurance, right? So it's likely, that could be a compromising position. It gets tricky though, depending on where. It's just hard to know. It's a little hard to know.
Yeah, I think it's a very interesting proposal, and I think I'm interested in what we know and don't know about how much employers like providing insurance, right? I mean, that's not what the employer does. They do something else. But all of a sudden, they're an insurer. They're dealing with insurance.
We know small employer groups
really
very
like
much
it.
dislike it.
Right, exactly.
And I think increasingly so, large groups are not terribly enamored with it because now it's very hard for them to make changes and still maintain worker satisfaction.
And how much do we like our employer-sponsored insurance? There are ways in which we do, and there's a huge churn in the insurance that we get offered through employers, right? And so this whole thing about we have to change doctors if something happens outside, we have to change doctors with employer-sponsored insurance frequently. There's a huge churn this was Lowell's paper, right? Lowell is a huge churn in the plans that we get offered. And so how much do we really like our employer-sponsored plan? If there was a public option that was similarly generous to what we have with our employer-sponsored plan, and we didn't have restrictive networks, I don't know that we know the answer to that question.
Well, the other thing is, I think it's one thing to ask somebody, how well do you like your health insurance plan? Another thing to say, no, we're going to take it away from you. And I think the latter elicits a strong response, a negative and fearful response. So something that had a policy that offers these things a parallel. If you like what you have, you can keep it, but there's going to be something else, and over time, people might discover that the alternative, whether it's Medicare buying, public options, what have you, is something they prefer. And for that matter, that might be the stealth way to a single payer, because if a public option comes out and it can keep its costs down and it's not restrictive, and moreover, if it doesn't actually have to balance its budget, if it can run a deficit and politicians won't pull the plug because that's a difficult thing to do, and guess what? Private health insurance plans, for better or for worse, can't compete. And there may be this giant sucking sound as the private health insurance market disappears. We're left with the public option, and we got a backdoor of a single payer system. That might be a good thing. It might not. I actually don't know about that, but it's certainly at least a plausible outcome.
Let's have just one more question.
Hi, I'm Brian. I'm a first-year healthcare policy and management student. This refers more so to like the political side, which we were sort of speaking to earlier, but Medicare for All is very viable within the Democratic Party, but then there's polling that suggests in swing states and in battleground congressional districts that obviously Republicans are not for it, but a lot of independents are very skeptical of Medicare for All, especially when they realize that under like Bernie's plan and then Senator Warren's plan that they're going to lose their private insurer. What are strategies to help combat that? What are the Democrats' plans to kind of overcome that? Or are those some unanswered questions that Democrats are still yet to address for this election?
I'm not convinced it's viable within the Democratic Party for the reasons we just said. And so I don't know. I mean, I'm not a political analyst, and I'm certainly not an advocate. But what we were just saying is something that offers people the option to retain what they have, in my view, if it's an amateur view, is a much easier sell than something that says, we're going to take something away from you. Even if you were complaining about it just 5 minutes ago.
And even if we're going to give you something better.
Right.
That's the part where I feel like there could be some movement. But again, I'm very far from a political operative. So, yeah.
Gene, thoughts?
You know, I think that what they need, you know, again, I'll kind of harken back to 10 years ago. It was the Republicans, it was a government takeover of healthcare, even though it strove to be a bipartisan effort at health reform. So I think there has to be something that is going to reflect some aspect of choice, competition, those types of ideals to be appealing to the center, or even to a little bit to the right. But it's going to matter how bad the affordability issue gets. And it's going to matter what the key stakeholders how they're going to respond to any specific proposal. And until we have a specific proposal, it's really difficult to predict.
All right, well, thank you all for that conversation today. If we could all give our panel a round of applause.